Welcome to Health Reform 2.0, the only place on the internet for people with a curious mind and a desire for a better healthcare system. Here we take you on a journey of our current quagmire, tell you where it came from and why the government can't fix it. Along the way, we'll tell you some history, bust a few big myths, tell you a few stories, and give you an idea how we can work together and get the healthcare system we want. Let's get started. In the last episode, we began discussing drug prices and why we believe they are so high. In this episode, we will continue that discussion and focus on the new program from Health and Human Services Secretary Azar on drug rebates. And we will discuss why the desired effect of this program may not be what we want it to be. So it's the problem in this thing is that everybody thinks there's money along the way. Well, there is money along the way. There's a lot of money along the way. The distributors don't make any money distributing the drug, but they do make money on rebates, volume-driven rebates. And if they hit a certain level of distribution of a drug, they get a big check. And the same thing goes up. Now, the average pharmacist doesn't get a rebate. Large chain pharmacies get rebates. So you got rebates at the distributor, you got rebates at the large pharmaceutical chains. You also have companies called PBMs, Pharmacy Benefit Management Companies. And what they do is they administer the drug costs and reimbursements for patients and insurance companies for various drugs, various programs. In fact, almost every PBM has access to manage the process for any drug through almost any pharmacy. It's a massive industry in and of itself. And PBMs also get rebates. So it's one of the reasons we thought when we were going to release generics were going to cost a lot less. Well, to incentivize the sale of the generic drug, they put a larger rebate on it.
Right.
Well, putting a larger rebate on it does what? It increases the retail price. And it's not a dollar for dollar increase because that rebate comes out a year after that product is sold to sometimes 6 months. So they sell the drug and at the end of the year, they get a big check back from the pharmaceutical company. So while the drug looks like it costs $100 at retail, that you're paying $100, first off, the reimbursement is about 22 cents on the dollar. So it isn't $100, it's about $22. And of the $22 that is paid by the program, the Fed, the state, the whatever, that $22 is often reduced down by as much sometimes as 40 and 50% because they paid a rebate back. They got a rebate back through the system for the drug they bought. So that annual rebate increments up the cost. We'll talk more about that later and put a chart up about it.
Yeah, that's going to be an important discussion. So this is an important point. When prescription drug benefits were added to Medicare, Medicaid under a 2003 law, and then the implementation of Medicare Part D 2006, the pharmacy industry successfully lobbied to prohibit the federal government from using its huge purchasing power to negotiate drug prices. Thank you very much, George W. Bush. The drug rebate program called MDRP is a program that includes the Centers for Medicare and Medicaid Services, CMS, state agencies, and participating drug manufacturers. The program requires a drug manufacturer, as Tom's already mentioned, to enter into and have in effect a national rebate program with the Secretary of Health and Human Services, HHS, today, Alex Azar, as you mentioned. In exchange, and here's the quid pro quo, ladies and gentlemen, in exchange for participation in national and state healthcare programs.
In effect, Tim, it's a mandatory federal drug rebate program.
Yeah.
So now you know why they didn't care about negotiating a lower price on the front end. If they got a lower price on the front end, they're getting a lower rebate back. Yeah. So they're actually losing money.
And that money was supposedly designated to go to underserved people, to AIDS patients, and it does in some cases.
Yeah. Well, it's mandated to go back into the program that it derives from. So if you get it through the Ryan White Healthcare Program, through Age Drug Assistance Program, they're called ADAP in a state. Technically, the checks that flow back to the state for those rebates are supposed to be spent on behalf of more drugs for HIV and AIDS patients. That's where it's supposed to go. But many states don't do that.
No.
And HRSA, who is responsible for the administration and oversight of these programs, has no teeth to do anything about it. So many states violate the law, and HRSA has no ability to go back and do anything about it.
It flows into the general fund.
Right. And get spent for night basketball games and covering the cost of pensions that are oversubscribed and underfunded.
I got one even better, but I'll wait because I'll get all out of shape here. Article in Modern Healthcare, February 4 this year. HHS Secretary Alex Azar last week predicted that commercial insurance plans are likely to eliminate drug rebates after a rule goes into effect that nixes a safe harbor for Medicare Part D and Medicare managed plans and rebates. All sounds good, ladies and gentlemen. Keep your eyes open on this. This is just a deflection in my mind. That's all this is. And I'm not sure if he's talking about the rebate to the government or if he's talking just to the PBMs.
The specific thing that's been talked about is PBMs for the most part. They haven't mentioned distributors, and they haven't mentioned large chain purchasers in this at this point.
Exactly. So there should be a chart up there. This is just an average of what some of these rebates may be. They're much bigger in some cases. They range from
17.5% up to 52 or 53% are the highest rebates. And these are, again, the averages across a class of drugs. And some of those drugs may have much higher rebates than the others.
So meet the rebate, the new villain of high drug prices. Tom, what's the best way to deflect attention off of you? Blame it on somebody else.
I blame it on you.
Exactly.
And it's his fault.
It's my fault. And, I wish I was getting some of these rebates. An increasingly popular culprit has been this rebate program. Really, they're after the fact discounts, by the way, ladies and gentlemen. After the fact, you have no visibility to this, no transparency. They're really kickbacks. And that's at the heart of the nation's broken system. Tom, you've had a lot of experience in this area, much more than I have, although this has been very educational, the research that was done. You've explained this in some of our previous episodes. Can you take a moment to get into a little bit more background of what the real meat is concerning the fleecing of the American people?
Yeah, and it goes back to what we showed you at the beginning, is supposedly we're spending $1,100 a year more than any other civilized nation on the planet for drugs. Right. But that number's false. It's false because the dollars that we're counting don't include the rebate that's reimbursed back to the states or to the various programs. It doesn't include that number. It includes most of the time the list price. Sometimes it includes the reimbursed price. In other words, what the insurance company or the state paid for the drug. But we'll use California as an example. California, a few years ago, spent close to $500 million on HIV and AIDS drugs for patients under their Age Drug Assistance Program. And they wrote checks for $500 million. So you say, okay, they spent $500 million. But they didn't spend $500 million because they got $243 million back in the form of rebates, either directly from drug manufacturers or through the Ryan White CARE Act reimbursements that were coming in through CMS. So this is a shell game. This is like 3-card Monte or hide the pea. We move this money all around, and then we tell you these great stories, or if we want you to believe we're spending a huge amount of money to cover your health care, well, we can give you data points that tell you that. And then the last point about fleecing is, if you look at France, if you look at England, if you look at Spain, if you look at Canada, we talk all this time about how the U.S. government is spending way more on services than these countries are. Well, number one is, remember, the data point I just gave you, that what we think we spend for these services is not anywhere near what we actually are spending. Typically, we're spending 20 to 30% less than what we claim. When the government says we're spending 3.8 trillion, we're not spending 3.8 trillion. We're actually spending in net about 2.1, 2.2 trillion dollars. But we also are counting every dollar spent in the private market and every dollar spent in the public market.
And they don't do that.
France doesn't do that because they don't, quote, have a private market. England doesn't have a private market, but they do have private markets. They're just not counted. They're off the books. And in effect, they're black markets. Spain has black markets. And many of these places, those black markets, those untracked markets, are 50 to 60 to 70% of what the expenditure is.
Right.
That more people get their care there because it's the only place they get choice. It's the only place they get the latest and the greatest kind of treatment plans. And it really falls back to the wealthy can afford to buy that. So we're being lied to at every corner by these professional politicians that exist in Washington to paint this story about how all this works with drug pricing and everything else. And it's not true.
Hey, don't look over here. Don't look there. Look here. Here, I got this whole thing, Medicare for all. Build a wall.
Yeah. And we'll be talking about
whatever it is.
That soon.
It is something to deflect you, and you need to research it and understand and educate yourself. That's, I think, one of the biggest problems we have in this country. We place a vote on something we don't know anything about.
Right. And we don't want to know anything about it because to know something about it means to do something about it. And it's just easier to blame the drug companies. And again, we're not saying there's no blame in drug companies. There's no blame in insurance companies. There's no blame in hospitals. But we would rather blame hospitals and doctors and insurance companies and drug companies because all these people are getting rich and we're not as rich as they are.
Yeah, we can sue them.
So it's convenient for us to find that as the excuse. And that's the game that the politicians play.
Complete denial. Between 2006 and 2014, prices for drugs rose an average of about 57%. But prices for drugs with no generic substitute rose 142%. We touched on that before.
Right.
So I'm going to go a little bit about how this current system works, and I'm going to kick it over to Tom to kind of dig into what it means. So this is how the current system works. It starts with a structure that looks healthy on the surface. What's the big deal? I'm getting a discount. Well, I will tell you why it's a big deal. Health plans pay their PBMs based on the extent of the discount that the PB can negotiate, as you mentioned.
Mm-hmm.
This encourages the PBM to drive prices down. After all, entities should bargain hard when their pay is tied to how much discount they can negotiate. Well, here we go again. This is not a supply and demand model.
No. It's I can manufacture any set of numbers I want, and if you believe it, I get the dollar model.
Exactly. The problem, as Tom mentioned, drug companies raise their prices so they could give a greater discount. You just mentioned that. This increases how much discount the PBM can claim to have negotiated, to your point. And the payout to the PBM is higher. It's a little like a department store raising prices right before a sale.
Yeah.
We've talked about that.
Yeah.
All of this may not be so bad if no one had to pay less price. But many people do. Many plans make patients pay full drug cost until they meet their deductible, and other plans require coinsurance, both of which are based on list price. As prices go up, your payment's based on list price. Many people do not have coverage for prescription drugs, even if they have health insurance sometimes. Thus, people are forced to pay the full list price at various times.
Mm-hmm.
Worse yet, the entire structure encourages drug companies to compete not by cutting prices, but by offering higher prices.
Exactly. It's a perverse incentive system.
Yeah, it's again, everything, and we talked about this before from the very beginning of our first episode, Everything we know about healthcare spending is wrong. List price versus what is paid and the discounts. Tom, what do you think about this?
Well, we've been now talking about this for a number of years. When I was working in the ADAP business, the AIDS drug assistance business, we had a PBM, we ran it. We didn't run it like other PBMs. In fact, we didn't like being called a PBM because that indicated kind of this whole little dynamic that existed. That's not how we operated. We made a commitment to the places that we ran programs that we would do it for 5 cents on the dollar or less. And if we did it for less, we would pass the savings back to the states. So it worked very well. In fact, the last year that I was there, we operated for one of the states, I won't mention which one, at 3.83 cents was actually what they paid us to process the claim. Mm-hmm. Most PBMs get paid a hell of a lot more than that to process claims and manage these things. But remember, it's not just the PBM, and it's not just the insurance companies or the others that are out there. It is the federal government, because if you calculate the total amount of money that's spent on Medicare and Medicaid and Ryan White ADAP programs, just for three, mm-hmm. and you calculate the total amount of money spent by the government to buy that product, and then you layer into it their average discount of 20 or 30%, and again, some of those discounts are as high as 55%.
Right.
Every year, every single year, the manufacturer of the drug gets charged at the end of the year with a rebate they have to pay back. And that new cost inflates their cost, which causes a corresponding increase in the retail price. Now, there's a chart on the screen that just shows what would happen with a $5 drug if we extended it out over the Medicare actuarial life of a product or a class of drugs, which is 75 years. It starts at $5 and it ends up at $12,500 a pill. That doesn't include inflation or anything else. And that's at an average rebate of 10%. So these are huge, huge problems. And these are where the real problem, and particularly drug pricing, is.
Yeah, so let me close this off with a final thought in one of my rants. This is a perfect example, and I keep saying, we need to educate ourselves. We don't take time. People don't take time, in my opinion, to educate themselves. I never did when I was younger, and I do now. But I'm going to go back, because we can show this on many different aspects of healthcare. You can see the same thing in just about everything else the government touches. Don't look over here. Pay attention to my soundbite. Medicare for all. What a joke that is. Build the wall. Well, you can't build a total wall. We all know that. I'm not playing politics, ladies and gentlemen. I'm just saying what they're doing to you. They're giving you sound bites to keep you from looking at the facts. Look at the facts. You know why they don't want you to look at the facts? It's because of this. It's because of the top 40 people in Congress people, their net worth went up 240% per year. Don't look here, ladies and gentlemen. Don't look at this. We don't want you to see this.
Right.
They didn't all do it by getting inheritance and by building their own businesses. Most of them are too damn dumb even to think about building a business or even understanding what the hell they're talking about half the time.
Right.
So think of that when you think about these programs, when you think about what's going on. Don't look at the shiny object.
Right.
Look at the truth.
And we can blame the politicians as well. But as I've said in the last couple episodes, you know who we really need to blame?
Us ourselves.
We need to blame ourselves, because we've allowed this to happen. Right. We've allowed this system to happen. And this is not an attack on any individual out there. This is an attack on all of us as people. And we talk about saving the middle class and protecting the middle class. But if we get a time this season, we'll do a show. I can show you mathematically how there's no way to protect the middle class, that the programs that are in effect are subsidizing the poor and taxing the middle class and the wealthy. But the taxes on the wealthy aren't affecting them because they have excess money to put in the stock market and get additional money back and hedge against the devaluation of the dollar. The middle class are getting squeezed. And what's happened is we've converted more of the middle class in the last 30 years from middle class to poor, because the definition of poor were people that couldn't make it on their own. Well, now there are subsidies for families of four that go up to $111,000 in earning. You can get a subsidy. So that means that over 57% of the United States is eligible and receiving a large percentage, over half of their income in some cases, from some form of federal program. And the reason they're receiving it is because we've created an economy that keeps driving the costs up in things like healthcare and drug prices. And that puts the squeeze on the poor, and then we give money to the poor, and then the middle class they don't have the money to invest, and they've got too much money to get the subsidies, so we increase the subsidies. The average subsidy in the AIDS drug assistance program when I was there was 400% of the poverty level. 400% was where the program started. The poverty level was where they were all originally designed to be. If you were considered impoverished, you got subsidies. But now we're at 400% of the poverty level, which just means that the poverty level has changed, but the government isn't telling you you're poor now if you make $89,000 a year.
So we'll leave you with that, ladies and gentlemen. Again, try to educate yourself. I know it's difficult because everyone's busy. Maybe get your nose out of the video games and open up a book or start doing some research. And, if you can't do that, then watch this podcast and we'll do it for you.
And tell your friends. Tell your friends. When you got friends that are telling you things that aren't right about healthcare and you believe we're telling you the truth, tell your friends to watch the podcast. Get people here. It's free. We don't get paid to do this. We do this because we believe that the story needs to be told. So we appreciate your attention and your persistence in coming back and watching our shows. And we invite you to help us change the system.
So long, everyone.
Bye. You've been listening to Health Reform 2.0 with your hosts, Tom Locher and Tim Henning. We hope you found the topics interesting, that we answered a few questions, that you laughed a bit and were entertained. Please feel free to invite your friends to join the discussion, and remember, hit that like button and don't forget to subscribe. Send us your questions to info@hr-20.com. We hope to see you again next time.